So my name is Marco, I'm a biochemist and I'm one of the co-founders of biotx AI. The biggest problem in pharma biotech is that we cannot predict clinical efficacy. So the bottleneck is actually phase 2 clinical trials where you only have a success rate of 30%. So this is the bottleneck. 10-15 years ago, there was then the idea of what's now called genetic support or human genetic evidence. So the idea is that the gene of the drug target is associated in big population studies with the disease. So it's likely more central for the disease. And GSK ran a big retrospective analysis 10 years ago where they looked at all successful and failed drugs, and they figured out if you have some genetic support, the success rate is almost 50% in a phase 2 clinical trial. And this was confirmed by AbbVie in 2019 with more recent data, and they claim it's almost 60%. So what we see is that human genetic evidence, so human genetic support, is now widely used in pharma for decision making. 2/3 of all FDA-approved drugs had genetic support in 2021. Nevertheless, we have to ask ourselves why it's only 60% and why it's not 100. I mean, in an ideal world where you check safety in phase 1 and you only focus on efficacy, why it's not more than 60%? And one of the reasons, this is just a correlation and it's not causation. Okay, so we have to talk about causality, the science of cause and effect. And the gold standard in causality is still the prospective randomized placebo-controlled trial developed in biomedicine. So biomedicine sets the standard in causality. But other disciplines are also very interested in causality, especially the economic sciences, but they do not have the resources to conduct prospective trials. So they went on to develop statistical methods to confirm causality out of retrospective data. And this is called causal inference. And this has been awarded with the Nobel Prize in 2021. We at biotx AI, we focus on one specific causal inference method called Mendelian randomization. So on the left-hand side, you see the concept of the randomized clinical trial. I guess the concept is clear. You have a population, you do a random allocation, one group gets a drug, the other gets a placebo, and then you control. Mendelian randomization works in this way differently, that you have retrospective data, so you cannot do a random allocation, but you assume there is random allocation based on the Mendelian rules. That's why it's called Mendelian randomization. But in reality, you now apply a causal inference method called instrumental variables, where you define genetic variants as a proxy for your drug molecule. So famous example, PCSK9, found in a GWAS 25 years ago. You would look at missense mutation in PCSK9, and then you can use them as a proxy for an inhibitor of PCSK9. So you would then check whether missense mutation carriers have lower LDL cholesterol levels. That's the idea. Okay, this is a real-world example, what you have done for GDF15, just to make it a little bit more, tangible for you. So you need always 2 genome-wide association studies to confirm causality. Here on the x-axis, you have actually GDF15 protein levels, and then you can actually check for genetic variants over here, what is their effect. And then you can see that this genetic variant, this has a strong effect for GDF15 protein levels, has also a strong effect for getting bladder cancer. And if the genetic variants, all on one line, and this is a kind of a simulation of an intervention, then you can claim there is causality. Okay, high level, genetic variant and the disease association in between are the omics data. Now then you can claim whether there's causality or not. So what we do at biotx is that we do it at scale. So Mendelian randomization was developed in the 80s of the last century. I always compare it with ChatGPT or neural networks. Neural networks developed in the 70s. Generative AI today is a completely different story, and it's because of the IT infrastructure, it's because of the algorithm, and it's because of the data. So we have gathered almost 25 million cases from all over the world, covering 3,000 diseases in our data set. So we can actually screen all 23,000 genes in 60 tissues via 1.3 million omics data points for more than 3,000 diseases. Okay, on the first slide, I showed you actually the retrospective analysis GSK has done 10 years ago, but is there also retrospective analysis for Mendelian randomization? And yes, now it is, because we were funded or we were supported by the German DARPA, Sprint, the Federal Agency for Breakthrough Innovation, and we run 4 million Mendelian randomization experiment for all successful and failed drugs. So these are roughly 25,000 gene disease pairs. For almost 1,500 diseases. And then we calculated the numbers. And with this data set, you see similar numbers as I showed you in the first. So without support, you have 30%, roughly 30% success rate in a phase 2 clinical trial. With genetic support, you have 60%. But with Mendelian randomization, so when you know that the target is causal and you're really sure about the pharmacodynamics of your targets, then it's 85%. Okay. That's one point. The other point is that you also can use this tool to get a better understanding of your target. So this is what we have done for the GLP-1 receptor, so the target of Ozempic. And here you can nicely see the mode of action, actually. So this is a hive plot. Here you have the GLP-1 receptor gene expression. And every line you see here is a successful Mendelian randomization experiment. So we tested higher expression of GLP-1 receptor against 9 type 2 diabetes data sets, and we only see for 3 a negative estimate, so more expression of the receptor, less type 2 diabetes. What makes sense, because GLP-1 is an agonist. Then we tested high expression of GLP-1 receptor against glycated hemoglobin, and you see also a negative impact here. But if you test hemoglobin again alone, then you see green lights. So because this is actually the causal agent of type 2 diabetes. And then you can also run other biomarkers. And in the next step, you can do it with the whole genome. So you can do it with every gene in 60 tissues, get these plots, and then you can annotate what are successful drug targets from the past, where you know that there are successful drugs on the market. And then you can actually run a machine learning classifier, and then you can rank what is the best drug target. Okay. How we operate, we have 2 business models or 2 engagement models. So with biotech companies, we work in a fee-for-service model. Price-wise, it's the same as when you go to Charleston for an animal model. And the other engagement model is our partnerships, where we work with company builders or platform biotech companies, or also with pharma. And this is not here disclosed, where we screen the whole genome and then we look what is the best drug target and predict based on existing drug targets what is actually the best drug target in the future. Yeah, and with this, I would like to thank you for your attention.